You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about deep venous thrombosis. We will go over diagnosis, management, including what to anticoagulate with and how long to anticoagulate, and what exactly we mean by provoked versus unprovoked. In this episode, we will include key highlights of the American Society of Hematology, or ASH, 2020 guidelines for management of venous thromboembolism, treatment of deep vein thrombosis, and pulmonary embolism. The guidelines for DVT and PE are primarily set by ASH instead of ACC or AHA. ASH uses a different class of recommendation system than the AHA-ACC's Class 1, 2A, 2B, and 3 system. In ASH, a recommendation can be strong or conditional. A strong recommendation means most individuals should follow the recommended course of action. Formal decision aids are not likely to be needed to help individual patients make decisions consistent with their values and preferences. Conditional recommendation means recognize that different choices will be appropriate for individual patients, that you must help each patient arrive at a management decision consistent with his or her values and preferences. Decision aids may be useful in helping individuals make decisions consistent with their individual risks, values, and preferences. With that, let's start with the diagnosis. How can you tell if something is a deep venous thrombus on ultrasound? A vein is thin-walled and not collapsible with compression. That's one clue. Another is that an echogenic mass is visible within the lumen of the vein. Or if you have an anechoic thrombus, you will see, in some cases, increased venous diameter and loss of phasic flow with breathing and augmentation with cough squeeze. You'll also see absence of color flow. These are the clues that something is a DVT on ultrasound. In contrast to a DVT, Baker's cyst ultrasound will show a well-circumscribed mass with an echolucent center. In contrast to DVT, arterial stenosis on ultrasound would show atheroma and have a significant increase in velocity on spectral Doppler and flow acceleration on color Doppler. When you have a DVT in an atypical location, you have to suspect that something is wrong with the organ it is coming from. Other than cancer, consider if a cerebral DVT is present, consider trauma, infection, or surgery. If portal vein DVT is present, consider it's telling you about cirrhosis or surgery or post-surgery. If a splenic vein DVT is present, consider it's telling you about an MPN, a neoplasm, or pancreatitis, or it's post-surgery. If a mesenteric venous DVT is present, consider it's telling you about inflammatory bowel disease, infection, or post-surgery. If renal vein DVT is present, consider that the patient may have nephrotic syndrome. If a gonadal DVT is present, consider that they have pelvic inflammatory disease. If they have a retinal DVT, consider that they have atherosclerosis. May-Thurner syndrome is when patients develop iliofemoral DVT due to an anatomical variant in which the right common iliac artery overlies and compresses the left common iliac vein against the lumbar spine. This variant is present in more than 20% of the population. Failure to correct this anatomy can lead to recurrent left lower extremity DVTs. Patients may also have left lower extremity swelling in the absence of DVT. That's May-Thurner syndrome. Now let's move on to management of DVTs. The reason for anticoagulation in DVT is both to prevent extension of the clot or embolism, such as progression to PE, and to decrease late sequelae of DVT, such as post-thrombotic syndrome and CTEPH. The risk of complications due to DVT is higher in proximal DVT. Therefore, there is a stronger indication to anticoagulate in the setting of a proximal DVT, i.e. femoral and iliac veins. The mortality rate in proximal DVT is significantly higher than that in distal DVT, i.e. DVT below the knee. So what should you anticoagulate with? For patients with DVT and or PE, the ASH guideline panel suggests using direct oral anticoagulants, DOACs, over vitamin K antagonists, VKAs, such as warfarin. That's a conditional recommendation. They say this recommendation may not apply to certain subgroups of patients, such as those with renal insufficiency with a creatinine clearance less than 30, moderate to severe liver disease, or antiphospholipid syndrome. In most patients with proximal DVT, the ASH guideline panel suggests anticoagulation therapy alone over thrombolytic therapy in addition to anticoagulation. Conditional recommendation. Thrombolysis is reasonable to consider for patients with limb-threatening DVT, phlegmasia cerulea dolens, and for selected younger patients at low risk for bleeding with symptomatic DVT involving the iliac and common femoral veins, higher risk for more severe post-thrombotic syndrome. For patients with extensive DVT in whom thrombolysis is considered appropriate, the ASH guideline panel suggests using catheter-directed thrombolysis over systemic thrombolysis, conditional. Now, how long do you anticoagulate? For primary treatment of patients with DVT and or PE, whether provoked by a transient risk factor or by a chronic risk factor or unprovoked, the ASH guideline panel suggests using a shorter course of anticoagulation for primary treatment of 3 to 6 months over a longer course of anticoagulation for primary treatment, 6 to 12 months. Conditional. Following completion of primary treatment of the initial VTE, providers must decide whether to discontinue anticoagulant therapy or continue with long-term anticoagulation with the intent to prevent VTE recurrence, referred to as secondary prevention. They say, after completion of primary treatment for patients with DVT and or PE provoked by a chronic risk factor, the ASH guideline panel suggests indefinite antithrombotic therapy over stopping anticoagulation. That's a conditional recommendation. After completion of primary treatment for patients with unprovoked DVT and or PE, the ASH guideline panel suggests indefinite antithrombotic therapy over stopping anticoagulation, conditional. For patients with unprovoked DVT and or PE, the ASH guideline panel suggests against routine use of prognostic scores, D-dimer testing, or ultrasound to detect residual vein thrombosis to guide the duration of anticoagulation, conditional. Indefinite anticoagulation is probably appropriate for the majority of patients with unprovoked VTE. However, in certain circumstances, such as when patients are undecided or the balance between risks and benefits is uncertain, clinicians may use prognostic scores, D-dimer testing, or ultrasound assessment for residual thrombosis from an initial DVT to aid in reaching a final decision. So my summary of this is, for a first provoked PE or proximal DVT, anticoagulate for 3 months. For a first unprovoked PE or proximal DVT, anticoagulate for 3 months, and then if low bleeding risk, continue it indefinitely. If you decide to stop after 6 to 18 months, such as later bleeding, then keep on aspirin at least. If it's a second PE or proximal DVT, then anticoagulate indefinitely. What exactly does provoked mean? Provoked means that it is secondary to a reversible or time-limited risk factor. If it is active cancer, then you have to coagulate that indefinitely. To blame surgery as a provoking event for DVT, it has to have been within the last 3 months. Transient risk factors, meaning risk factors that resolved after they have provoked a VTE, include major and minor factors. Major transient risk factors include surgery with general anesthesia for at least 30 minutes, being confined to bed in a hospital for at least 3 days with an acute illness, i.e., bathroom privileges only, and C-section. These are the major transient risk factors that must have occurred within 3 months of VTE diagnosis. Minor transient risk factors are surgery with general anesthesia for less than 30 minutes, admission to a hospital for less than 3 days with an acute illness, estrogen therapy such as oral contraceptives or hormone replacement therapy, pregnancy and puerperium, being confined to bed out of hospital for more than 3 days with an acute illness, or leg injury associated with decreased mobility for more than 3 days inclusive. These are the minor transient risk factors that must have occurred within the 2 months of VTE diagnosis. Chronic persistent risk factors, meaning risk factors that are still there and are going to be there indefinitely after development of VTE, are active cancer, for example, ongoing chemotherapy, and also includes recurrent or progressive disease, inflammatory bowel disease, autoimmune disorders such as antiphospholipid syndrome or rheumatoid arthritis, chronic infections, or chronic immobility such as spinal cord injury. These are chronic risk factors for VTE. Non-environmental risk factors for VTE include hereditary thrombophilia, older age, and male sex. These variables typically exhibit a low relative risk for VTE, but may be useful in combination with acquired risk factors when considering an individual's patient's risk for recurrence. When do you test for thrombophilia? Do not test at the time of a VTE event. Do not test while on anticoagulation therapy. You typically need to have been off anticoagulation for at least 2 weeks to test for thrombophilia. Do not test if there's an obvious major risk factor, such as major trauma, major surgery, immobility, or major illness. Do test if the patient is young age and has weak provoking factors, or if the patient has a strong family history of VTE, or the patient has recurrent VTE. Antiphospholipid syndrome diagnosis requires repeating lab testing at 3 months to make sure it is still positive. Other than lupus anticoagulant, there is anticardiolipin IgG or IgM and beta-glycoprotein IgG and IgM. Lastly, we'll very briefly say a few words about lymphedema in this DVT section. Lymphedema is not the same as DVT. Lymphedema should be painless and cause non-dependent edema. Causes of lymphedema are cancer, which is the most common cause in developed countries, congenital, debulking surgery from lymph node dissection, radiation therapy, and recurrent infection from tinea pedis. Lymphedema is diagnosed clinically and confirmed with lymphoscintigraphy, not a lymphangiogram. That's all for DVT. I hope this was useful to you.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.